So hopefully, you've done all the preventive things that Dr. Shibuya was talking about, and don't end up with clinical disease. But if you do, this is going to be helpful in terms of what we have to offer, and how we take care of things with rheumatoid arthritis. Just before we go ahead, I just want to let you know that this is not meant to be medical advice. Because each situation is different. There's no one thing that fits all. It's always tailored, and always take all the recommendations, your questions to your physician, and clarify whether it is relevant in your case or not. Okay? And most of the slides here are from the American College of Rheumatology, but I have a few ones that I've chosen from the internet, which I've given references to. What is rheumatoid arthritis? It is in some way the the archetypical rheumatology, the bread and butter of rheumatology, and it is by far the commonest type of inflammatory arthritis. It is a chronic disease affecting joints, and does involve other organs as well. By chronic, we mean the symptoms being present for at least 6 weeks or more, because you can have transient joint pains that can be part of an illness, a viral infection, and those tend to get better on their own. But if something persists beyond 6 weeks, then we start to think about rheumatoid arthritis. The main feature of rheumatoid arthritis is inflammation, and you see the inflammation in the joints, you see the inflammation in the rest of the organs that can be affected, and eventually it can lead to deformities. So in this picture, this is inflammation starting, and here, and eventually it can lead to deformities in the joints or the extremities involved. Just like Lavon was telling us, about 1.2 to 1.3 million Americans have rheumatoid arthritis, and it has a female preponderance. In fact, 1 to 3% of women may get rheumatoid arthritis in their lifetime. And the risk is higher if you have a first degree relative with rheumatoid arthritis. So that speaks for some genetic predisposition, which we'll go over later. And although symptoms can start at any age, it's frequently diagnosed in the 4th and 6th decades of life. But they can present at pretty much any age, including the 20s and 30s. And even kids get arthritis. It's called juvenile arthritis. So before we go on, what I would say is I'll finish my talk, and then I have time for questions, and then go on to the next topic. So please note down your questions. So when do we suspect rheumatoid arthritis? Again, we talked about symptoms persisting for at least 6 weeks, and there's pain and stiffness and limited movements, and especially stiffness in the mornings, when you wake up in the mornings in the hands and the feet. Again, wrists, knees, shoulders, hips, all these joints can be involved. There's a very common dry eyes and dry mouth syndrome that goes along with rheumatoid arthritis. That's called Sjogren's syndrome. Again, that's inflammation of the salivary glands. And the other feature which we can see in very active rheumatoid arthritis is sometimes these lumps called rheumatoid nodules, which are these fleshy outpouchings. Folks can also be sick with fevers, generally not feeling well, a lot of fatigue. And these are some of the typical joint manifestations, or how the joints look in rheumatoid arthritis. If you see, this joint involvement is very typical for rheumatoid arthritis, and there's almost nothing else that looks like this. And again, the equivalent of these joints in the feet is these joints, which we call the balls of the feet, and these are also very typically involved. And these are the fleshy swellings we talked about. Again, there are other organs that rheumatoid arthritis can involve, and these include the eyes, and we talked about the dry eyes, dry mouth syndrome, Sjogren's syndrome. Lungs can be involved. Folks can have inflammation in the lungs as well. Folks with rheumatoid arthritis are at higher risk for heart disease. In fact, it's as much as 2 times, for folks without rheumatoid arthritis. Very rarely the kidneys can be involved, and the skin, we talked about the nodules. You can have intestinal involvement with rheumatoid arthritis as well. So it can pretty much involve a whole gamut of organs, but the most common ones we see are the joints and the dry eyes. And one common question we always get is, how is it different from osteoarthritis or the wear and tear type of arthritis, which I believe Dr. Lin is going to talk about next, is that the pattern of joints involved is very different in osteoarthritis. And again, this is for a rheumatologist, for a trained eye, we can tell the difference. But in case you have any questions, you can always approach your primary care, to see if they are able to help you with this, or maybe refer you to a rheumatologist. But these bunions, this is a bunion, and these are what is affected in osteoarthritis as opposed to rheumatoid. You can see that these joints are not typically involved in the more common type, which is the osteoarthritis. In terms of what causes rheumatoid arthritis, we do not know the exact cause. It is an autoimmune disease in that the immune system, instead of fighting the viruses, the bacteria, start to turn against the body's own self, the joint tissues. Various things have been postulated, maybe molecular mimicry, where the viruses and bacteria share the same structure with the joint tissue, and maybe it gets fooled into attacking the joints. So that's one of the things. And what happens is, because of that attack, you have inflammation and release of chemicals. And these chemicals, one of the major chemicals of which is the TNF, which are the targets for treatment. They cause a lot of fatigue, anemia, in addition to damaging the cartilage and bones. And there are certain inherited genes that we have identified that can make folks more susceptible to rheumatoid arthritis. It's not, it's not something we do in clinical practice, is to test for genes, but it has been done. And just to let you know, what you see, I'm pointing here, is the normal joint. A normal joint would have two bones meeting, and there's a nice blue cartilage between the two, and there's a small amount of fluid that buffers the movement of the joint. And this thin lining is called the synovial membrane. What happens in rheumatoid arthritis is this synovial membrane is irritated for some reason, whether it's the antibodies or something irritates the synovial tissue, so it grows, it secretes fluid, so there's increased fluid, and eventually it becomes fleshy, and that's what gives you the swelling that you see in the joints in RA. Okay? And eventually it can destroy the cartilage, so the nice thick cartilage here is being eroded, is being eaten up by this swelling of the synovium. Eventually such that this might collapse and lead to damage or osteoarthritis. This here is called an erosion. It is eating up, I'm sorry, let me go back, of this particular edge of the bone. This is again very typical for rheumatoid arthritis. And studies have shown that these erosions are responsible for, are correlated with disability and inability to use the joint. So we focus on preventing these erosions. They may even heal somehow, but basically prevent the erosions from progressing further, all the medications we have. Okay? Again, this is just to give you a comparison, this fleshy synovial thickening compared to this nice thin membrane we have here. And this is the more common type, which is the osteoarthritis, where the basic problem is just collapse of the cartilage and bone on bone, as opposed to this fleshy swelling you have. How do we diagnose rheumatoid arthritis? Early on, symptoms kind of can be non-specific, and you're not able to, especially if it's early, difficult to do it. But a rheumatologist is trained to identify the telltale history and typical findings on exam. And that's when the primary care physician runs a few tests and suspects arthritis and sends the patients to us. There are some blood tests that might indicate the presence of rheumatoid arthritis, but I want to stress here that rheumatoid arthritis is a clinical diagnosis. There are some folks who will have a negative blood test yet have typical symptoms, and we diagnose them with rheumatoid arthritis. But commonly there are these two factors called rheumatoid factor and anti-CCP antibodies. They are two antibodies we identify in the blood to make the diagnosis. In addition, folks also have high inflammation levels. These are the two things we check for inflammation. Folks can be anemic. And also typical findings on X-rays. The thing with X-rays is the disease has to be present for a certain number of certain amount of time before changes on the X-rays can come up. But with MRIs, we are able to catch arthritis early on. So ultrasound is another technology that is used to diagnose early arthritis. So between the MRIs and the ultrasound, we are now able to pick up a lot more arthritis earlier and get on board with the treatment, as opposed to waiting till we see the changes on the X-rays, which typically take a few years, unless they're very aggressive, usually take a few years to show up. And the bottom line is that there is no single test that can diagnose rheumatoid arthritis. It's a combination of how they present, how their labs look, and all of that being put together to make a diagnosis of rheumatoid arthritis. And just to, as we were talking about the X-rays, these are some of the typical changes that you can see on X-rays in rheumatoid arthritis. As compared to a normal joint where you have a normal space between the two bones, and there's a nice amount of cartilage between the joints. And here you can see that the bones have, kind of collapsed. There's, deformities, and there's erosions that we try to prevent. In terms of treatment, it has improved by leaps and bounds. In the 50s, all we had to offer patients was steroids. We didn't have any of these medications we have now, and more often than not, patients would be seeing orthopedic surgeons more than they saw rheumatologists. But now we have really good outcomes for rheumatoid arthritis, and patients who are newly diagnosed will never end up looking like this, may never. In fact, we're able to put patients in remission now, where we really don't cure it. There is no cure for rheumatoid arthritis, but they improve to such an extent that there's almost no disease activity that is noticeable. And this remission concept, from oncology, from our cancer specialties we borrow, we do the same thing in rheumatoid arthritis now. But the aim is to start early. The more aggressive we are, the lesser medications we can get away with, and the smaller dose. And again, there's no single drug or regimen. It's always tailored to how it suits a person. And again, it is a multidisciplinary approach, which involves help with the patient's primary care physician. We often refer them to physical therapists, occupational therapists, and eventually if folks need any kind of intervention, to orthopedics. And I think this is where the holistic medicine thing would also come in, because as much as we love to spend time counseling patients on diet and lifestyle and all that, just discussing the medication and their disease itself takes away most of our time. So I think that's a great complement to what we do. So in terms of treatment, we can think about treatment in two broad terms. One set of treatment that I've listed here focuses on decreasing the swelling, the pain, give kind of immediate relief. And these include anti-inflammatory drugs, ibuprofen or Motrin. And the other set of drugs are steroids or glucocorticoids. Again, they can be given by mouth, or we can give them as shots directly in the joint that is affected, and that helps to decrease the pain and the swelling. But again, these medications do not modify the course of the disease. This is pretty much what we had in the 50s, for example, and these don't prevent your hands from getting from here to here. For those, we have newer medications called disease modifying anti-rheumatic drugs. We'll use the term DMARDS for that. So what we aim for is relief of symptoms, but also to slow disease progression, and more importantly is to improve quality of life. Okay? And there is some evidence that these medicines may cause some healing of those bony erosions, but more importantly they prevent it from getting worse. In terms of treatments, there are three main categories of treatment. So these are some of the terms that are recently we've been using for these medications. There's one called synthetic DMARDs, which are the older traditional medications. And then there's a newer category that's called targeted synthetic DMARDs. And then there are biologic DMARDs, and I'll go over each of them separately. So these synthetic or traditional DMARDs, for example, methotrexate has been around for about 50 to 60 years now, and others in this category are also listed. These are mostly chemical medications as opposed to the biologics, which I'll talk about, and these help to decrease the joint damage progression. These medications do have side effects, and before your rheumatologist recommends this for you, he or she will discuss all the risks, the benefits. Most of these need regular blood work monitoring or monitoring for potential eye damage and things like that. We almost never use gold now. It used to be used before. There's a high incidence of kidney toxicity with it. And minocycline has, is not in fallen out of favor as well. In fact, the first 5 are most commonly used. Brand new category of medications is what we call the targeted synthetic DMARDs. And again, going back to these, the way these medicines act is they interfere with rapidly dividing cells. So remember, the irritated synovial tissue is rapidly dividing to make those cells, and these medicines kind of tune that down, and that's how they prevent this from growing more. These drugs do the same thing, except they target very specific pathways. And I don't know if the immunology talk this morning covered it, but there is something called a JAK kinase pathway, and this tofacitinib or Xeljanz addresses that particular signal. But again, the side effects of these are slightly more comparable to these medications, which are called biologic DMARDs. So biologics are special medicines that are engineered in the lab. It's kind of set a thief to catch a thief. So these are antibody against inflammation proteins. And so they make TNF. Remember, TNF is a inflammation protein that we talked about before. So some of these are antibodies against the TNFs. We call them anti-TNFs. Others address something called IL-6, which is an inflammation protein. Okay? So there are various targets that are recognized, and these medications are targeting parts of the immune system signals. So remember, rheumatoid arthritis is a hyperactive immune system that's attacking your joints. These tend to tune that down. And the downside of that being, the immune system also helps to fight infections. So you may compromise on your ability to fight infections. So that's why before you start on any of these medications, your rheumatologist will screen you for hepatitis, for TB, any of those infections before considering this safe for you. Okay? And studies have shown that these medications are best combined with these other synthetic DMARDs. So a combination works the best. But in your individual situation, if you have, for example, you have a damaged liver, you cannot take some of those other medicines, then we tend to use this by themselves. And this is also a part of treatment for rheumatoid arthritis is joint damage. When the joint damage has progressed beyond, a certain point, then getting new knees or new hips, joint replacement is part of it. And again, exercise and lifestyle changes, very critical. Low impact aerobics and walking is highly recommended. 6,000 steps a day to prevent osteoarthritis recently been described. And its health benefits are not only for the joints, which it helps to relieve pressure, but it also helps cardiovascular health. And remember, rheumatoid arthritis patients have a higher risk of heart disease. Quitting smoking is really important, and the reason being that one of the things that has been shown to be associated with aggressive rheumatoid arthritis is actually smoking, especially with the anti-CCP antibodies. Folks who smoke tend to have anti-CCP antibodies and more aggressive disease. Again, just like Dr. Shibuya was talking, if you're not sure what kind of exercise is good for you or you're able to do, we can send you to a physical therapist or an occupational therapist who can tailor your level and pace of exercise. Of course, when you're having a flare of arthritis, when the arthritis is acting up, we would want you to rest, but definitely continue range of movement exercises, just keeping the joints nimble. Yes.
What gives you a flare-up of arthritis? I don't understand.
Okay, so flare-up of arthritis is initially when folks present, they are in pain and stiffness all the time, and then we give them treatments, and things settle down, their pain and stiffness gets better, but periodically the pain and stiffness levels can go up, and they can get these episodes of fatigue, fever, where the arthritis is not under remission or not in control. Okay, and that can happen because this is a lifetime of illness with ups and downs. So the the up or worsening disease activity is called a flare. Okay. Again, in terms of prevention, cardiovascular disease, making sure your cholesterol levels are good, controlling blood pressure is really important. Again, we talked about smoking and exercise. There is some evidence that periodontal disease, gum disease may be associated with rheumatoid arthritis. There are some shared proteins between certain gum bugs and rheumatoid arthritis. So, good dental hygiene may help. Again, you have to work closely with your doctor in terms of recommendations for lab work, vaccines. It's really important to keep up with all the immunizations which are relevant for you, and also to comply with those treatment recommendations. Okay. Again, to learn more, some great resources are Arthritis Foundation, the American College of Rheumatology, and local chapters such as the NCRS. And we have a website as well. I tried to bring it on the internet here, but I couldn't. But NCRS also has a website with very useful information, links that you can go on to learn more, and you can get on some of their e-newsletters or communication modalities. And again, just to let you know that this is not meant to be medical advice. This is a brief version of, there's a lot to talk, there's probably a lot of questions on this, but I try to put everything in a short, terse form without going into details. But if you have questions on any of those, I'm happy to answer those for you. And that's it. Okay, any questions? All right, then let's move on to our next topic. Now, unlike rheumatoid arthritis, vasculitis is a very rare disease, okay? And there are some forms of it that we tend to see, which we may not recognize as vasculitis, but we'll go over those. Again, this is, so what is vasculitis? So vascular means blood vessel related, and itis means inflammation. So vasculitis means inflammation of blood vessels, okay? Again, these are rare diseases, and unlike rheumatoid arthritis, which is more common in women, vasculitis can affect pretty much any age group. Kids get it, older folks get it, men, women, but there are certain types that are more common among different age groups. And so this is, how a normal artery should look, with the, smooth contours of the walls, normal blood flow. But in vasculitis, you have, the wall being thickened, outpouchings, dilations. So that is what we call vasculitis. And again, vasculitis may involve both arteries and veins. And again, just to recap, arteries are blood vessels that carry oxygenated blood away from the heart, and veins are these bluish structures that collect the deoxygenated blood back to the heart. So the result is that when the blood vessels are affected, it results in poor blood flow to the tissues. And because every tissue has blood supply, pretty much any organ can be affected. Okay? But most commonly involved are the lungs, nerves, kidneys, and skin. And I'll show you some common involvements. So again, you can have a range of signs and symptoms of vasculitis. Again, remember, signs are what we see and symptoms are what you feel. Okay? It can be from anywhere from mild to fatal. So vasculitis could be pretty serious. For example, if it's in the kidneys, it usually does not produce any symptoms of what you feel. It's just detected by blood tests and by urine tests. On the other hand, if you had nerves involved, such as this, you could have what we call a wrist drop or a foot drop, or tingling and numbness in the hands and feet, and the skin can commonly be involved in terms of these red spots in the skin, which we call purpura. And these are very telltale for vasculitis. So, when your health practitioner looks at this, he or she suspects this and runs some blood work based on this. You can also have, again, ulcers in the skin as well as part of the vasculitis. It can also affect the brain when you can have headaches and weight loss, fevers, confusion. It can result in mouth sores, nose sores. It can result in shortness of breath and cough if the lungs are involved. It can also result in fingertip necrosis, or what we call dying off of tissue, because there's not enough blood supply to the tips of the fingers. And these are some other forms of vasculitis without going into names. Some of the very classic things you can see are, if you look at how nicely blood flows in this part of the blood vessels which are not involved, versus these areas of thickening and then constriction, almost like a beading. Here is where the blood flow is affected, and this is the blood supply to the gut. So you can have vasculitis of the intestines here. And this is in the kidneys. Again, you see all these outpouchings instead of a nice smooth line. That's blood flow to the kidneys being affected. And this is again blood flow to the tips of fingers. You can see that there is an abrupt cutoff and there's no blood supply at all in these fingertips. And that's vasculitis of the blood vessels in the hands. And this is a very typical deformity of one of the types of vasculitis we call Wegener's. Or GPA. It's very rare, but it can destroy the cartilage of the nose. In terms of what causes vasculitis, mostly we don't know the triggers for it, but again there is a genetic predisposition, and we can actually look for a gene. We do that in the office that can put you at risk for some of the types of vasculitis. Especially something called Behçet's. There's a particular gene associated with it. And on top of a genetic predisposition, there is an autoimmune phenomenon. So somebody has the genes that they inherit that puts them at risk for it, and there's something from the outside, either a bacterial infection or a viral infection or some change in the body that triggers the immune system in that predisposed individual that starts to attack the blood vessels. Okay. There is a type of vasculitis that can also be seen with rheumatoid arthritis and Sjogren's and lupus. So, if you have some of these other rheumatologic diseases, you can have vasculitis as part of that as well. There are certain types of vasculitis that can be caused by medicines, and those are pretty easy to treat in that you stop the medicine and that mostly resolves on its own, maybe with a little bit of treatment. And there are certain chronic long-term infections such as hepatitis B and C, which can also result in vasculitis. This is just a summary of all the types of vasculitis. There is lots of types, but the type that you commonly probably will encounter is something called giant cell arthritis, which is a vasculitis of large vessels. Again, this column here tells you that it's divided according to the caliber of the blood vessel involved or the type of blood vessel involved, whether it's the largest arteries such as the aorta, whether they are medium sized arteries or whether they are small arteries. We can classify them based on the caliber of the artery involved. And the other way of classifying them is to say both arteries and veins are involved, okay? Of which the most common is what we call giant cell arthritis. It tends to happen in folks over the age of 60 who present with headaches, double vision, and there's basically an artery that runs right in front of the ear that gets inflamed and may lead to blindness. I mean, the good part of it is it can usually be treated with steroids for a couple of years, 1 to 2 years, and then we are able to wean them off. There's one other kind of vasculitis that is self-limited, especially in kids. It's called IgA vasculitis. It tends to mostly have a good prognosis. There's one called Kawasaki disease, which is exclusively seen in children. So if you have questions on any particular type, we can go over that, but that's the general types of vasculitis. So when do we diagnose it? So the most important point is these are rare diseases. So these are not the first suspect, because there are a number of other things that can cause fevers and weight loss and headache. There's a lot of explanations other than vasculitis for it. Once we've eliminated all of those, then we start to focus on possibly this being a diagnosis. And some of these we can diagnose based on the pattern of involvement alone. If we know that it causes ulcers in the mouth or nose and so, and we are able to put that together and make the diagnosis. There is a blood test called ANCA, or anti-neutrophil cytoplasmic antibodies, which are very particular for certain types of vasculitis. Most of the times what ends up happening is we do a biopsy, which is remove a piece of the tissue, whether it's the involved skin or the kidneys. We even ask for a brain biopsy if we have a vasculitis in the brain, and that's when we make that diagnosis very definitively. But as a surrogate to it, we might sometimes do what we call an angiography, or just image the blood vessels, and if we see very typical features such as this, narrowing of the blood vessels, or this outpouching here of the aorta, we are able to make the diagnosis as well. And the way we treat it, the mainstay of treatment is glucocorticoids or steroids. Steroids do have a lot of side effects, but when the question is whether it's life or death and long-term side effects, these tend to be used as rescue medications to kind of stabilize a patient, to prevent death and to prevent damage to vital organs. And then we generally move on to other immune suppressing drugs, which we call steroid sparing. And there are a number of ones, a couple we use for very severe disease, and sometimes we may also resort to plasma exchange when folks are really in trouble. And then there are a couple that we use that are also used in rheumatoid arthritis that we use for treatment of vasculitis. Sometimes when the blood flow is severely affected, they may have to undergo surgery to revascularize or to redirect blood flow around the blockage. And sinuses may be involved in a particular type of vasculitis. Folks may need sinus surgery. If the kidneys are involved and they lose kidney function, they may need a kidney transplant. The most important goal there is to prevent death and vital organ damage and to prevent long-term disability. Now, other than these very life-threatening symptoms, there's also other things that affect quality of life. Folks can be in a lot of pain, fatigue is very troublesome, nose and sinus problems, arthritis, and this is where kind of getting a holistic approach to things, and lifestyle management, the positive attitude, treatment of depression if there's any, all these kind of play into this quality of life. There's also a lot of side effects from these medications. We talked about glucocorticoids in particular, and some of these immune suppressing drugs can make folks more susceptible to infections. So you have to work really closely with your rheumatologist to really try to be aggressive and catch infections early on, and to tweak medicines if you have side effects from those. So it would be very tailored. Again, in summary, vasculitis could be just short term. I talked about giant cell arteritis and some IgA vasculitis in kids. They are usually short term, or it can be a lifelong illness. Very important to work closely with your rheumatologist to find the right treatments. But we generally, the outcomes for folks with vasculitis is good now. We have very potent agents that can help them out. Any questions? Okay. Yeah.
Do we have any idea why the vasculitis might occur with certain things like lupus, rheumatoid arthritis? Do we know why it might show up in those
It's probably related to the common mechanism of inflammation or damage that occurs in other parts. So, the question is in other diseases such as rheumatoid and lupus, why do we see vasculitis? So, you can think of it as inflammation occurring in the joints or in the blood vessels. In the joints predominantly, rheumatoid, it's the same mechanism that may be at play, in terms of inflammation in the blood vessels as well. For definitely we know of antibodies that exist in rheumatoid arthritis, in lupus, and it may be the same mechanism of action, but we still do not have a full understanding of what triggers the vasculitis. And again, there are certain telltale findings in the skin and on the arteriography. If we see those, are very typical for vasculitis. Otherwise, it's pretty rare. These are rare diseases. Yes.
Is it common for vasculitis to show up like very quickly, or does it just come on slowly?
So the question is, can vasculitis come on quickly, or can it come, it's kind of a subacute slow onset, right? It can be pretty sudden, fevers, headaches lasting just a few days. It can be pretty sudden, although most patients tend to be, chronic, tend to present chronically, especially the giant cell arthritis that we were talking about, where they have inflammation here. They tend to have fevers and not feeling well for a few months before somebody actually thinks of it and does a blood test to look for inflammation, and that's when the diagnosis is made. So most of the times it tends to be chronic, comes on over time.
I just was wondering because I have lupus and I got vasculitis in my intestines, and it came on like within hours, and I lost most of my intestines.
Right.
And that's why I was wondering, is it rare that it comes on so quickly, or?
No, it can. It can. For example, the primary vasculitis diagnosis, not the ones related to rheumatoid and lupus, but the primary vasculitis kind of picture can go undiagnosed for a few months because nobody just thinks of it, first line, and that may be the reason why we don't catch it, but it can be quite sudden.
Does vasculitis have any correlation with nerve damage too then, or no?
So you can have vasculitis of, so the question is, does vasculitis have any relation to nerve damage? So even the nerves have blood supply, and when those blood vessels supplying the nerves are affected by vasculitis, then you have damage to the nerves, and that's when you can have either loss of function or you can have tingling and numbness of the hands and feet. Yeah.
Is it fair to say that if there is no genetic predisposition, occurrence of vasculitis is not possible?
So the question is there a genetic predisposition always? Is that the question? That's poorly understood. That specific relationship has been there only with one or two specifically identified genes, but otherwise we don't know that what the genetic association is. It's not like, maybe we haven't recognized it yet, but there's very few that have a specific genetic association.
If there is, in addition to instead of doing biopsy and angiography and genetic testing,
no, that proven relationship is there only for a couple of diseases. For example, for something called Behçet's syndrome, we have an HLA B51 gene that we can test and say, oh, you have all these symptoms plus you have this gene, you probably have Behçet's. So in that case, I'd feel comfortable not getting a biopsy or an X-ray, like an angiography. But that is available for very few, maybe even just the Behçet's, not all the other types of vasculitis.
Is vasculitis responsible for trigeminal neuralgia?
So the question is, trigeminal neuralgia, can it be a vasculitis? So trigeminal neuralgia is, there's a particular nerve that supplies the face, the sensory distribution to the face, that can get, start firing on its own and results in very painful areas in the face, and that can be triggered by touch. So it can be a vasculitis. So if there is blood supply to that nerve, if it's affected by the vasculitis, it can lead to trigeminal neuralgia. So yes.
Currently, before I developed RA, I had severe off all of a sudden. Is there a connection ever? Do people ever see a connection between allergies, which are also immune system as well?
So we get this question all the time, and the question is there a relationship between autoimmunity and allergy, right? Autoimmune diseases and allergies. They're two distinct branches of immunology. It's the same part of the immune system. It is part of the immune system, but it's a different branch, allergies and autoimmunity. But there are, for example, there is one disease called Churg-Strauss, which is associated with high levels of eosinophils and can lead to significant, eosinophils, which are again associated with allergies. That's when they may get misdiagnosed as allergies and be treated for asthma, and then find out that it's actually part of this vasculitis. But in general, there is no correlation between allergies and autoimmunity. They are two different branches of the immune system. Yes?
A question related to that about RA.
RA,
You had mentioned that hyperactive immune system is one potential cause of RA, but it's also linked to allergy, severe allergies, right? So is having severe allergies and having the RA or?
So the question is, if you have severe allergies, can you have severe RA, right? So the immune system has different branches. So the allergy arm is different from the autoimmunity arm. The types of cells involved are different than in the ones involved in autoimmunity. So it does not mean that if you have severe allergies, you have severe. They are two different regiments of the army.
So I have a question. So are you saying, I've been told before, if you have one autoimmune disease, you're more likely to get more autoimmune deficiencies. So you're saying that autoimmune of asthma is not related?
Asthma is not an autoimmune disease.
Okay, well, allergies.
Allergies.
The IgEs
Yes.
and IgAs and
Yeah.
whatever.
Yeah.
But they're not related?
No. Except for, I mentioned that there is this particular type of vasculitis called Churg-Strauss that may be associated with asthma, and that's because of the IG. That's the only place where the two may come together, but asthma is not an autoimmune disease. It's, for the immune system, autoimmunity, it's the B cells and T cells that are more important, which are as opposed to, eosinophils and macrophages in allergies. I mean, there is one exception called mastocytosis, which can be associated with severe itching and allergies, but it's a rare phenomenon. So not in general, they're both different. Well, I guess we've overshot. Yeah, okay. Thank you so much. More questions I can take off.